Hi, we are going to discuss regarding respiratory disorders of newborns. If you are coming to the respiratory disorders of newborn, first one is surfactant deficiency. Surfactant deficiency is nothing but the deficiency of surfactant production will cause surfactant deficiency in the newborns. Usually, this endogenous surfactant is produced by type 2 pneumocystis, which line 5 to 10% of alveolar surface. It's lining 5 to 10% of alveolar surface, and the surfactant containing osmophilic granular inclusion bodies causes this to appear different from the thinner and more numerous type 1 pneumocystis. So usually the surfactant helpful for gas exchange. When there is a deficiency of surfactant, it will cause problem in the gas exchange in the newborns. Next, if you are coming to the estimated incidence of surfactant deficiency according to gestational age, if it is 26 completed 26 weeks, maybe 90%. If 28 completed weeks, 80%. 30 completed weeks, 70%. 32 completed weeks, 55%. 34 completed weeks, 25%. 36 completed weeks, 12%. 38 completed weeks, 3%, and 40 completed weeks less than 1 or 2%. And this surfactant deficiency is decreased in female newborns, and premature rupturing of membrane, maternal opiate uses, intrauterine growth retardation, and antenatal glucocorticoids, prophylactic surfactant. In this condition, we can see the decreased incidence of surfactant deficiency. Next, if you are coming to the increased surfactant deficiency, we can see in male babies sepsis, in baby with sepsis, and premature babies maternal diabetes, and second twin if any family history and elective cesarean section. In these cases, we can see increased surfactant deficiency. So, how to manage this surfactant deficiency? Maternal antenatal corticosteroids before preterm birth to reduce this effect of surfactant. Dexamethasone. So it will reduce neonatal mortality 31%, decrease intraventricular HEG, and also it's reduce risk of necrotizing enterocolitis. It reduce risk of infection in first 24 hours, and it decrease the need of respiratory support for respiratory distress syndrome. Next, second condition is chronic lung disease. Chronic lung disease, otherwise bronchopulmonary dysplasia. What is this chronic lung disease? In very low birth weight babies, infants, an alternative has been suggested required oxygen plus one mechanical ventilation less than 36 weeks, corrected gestational age, and typical chest X-ray changes. Then, if you are coming to the risk factors of chronic lung disease, prematurity, prolonged mechanical ventilation with high pressure, volume trauma, pulmonary hair leak, gastroesophageal reflux, patent duct arteriosus, and pulmonary infection. Next, if you are coming to the management like ventilatory support and supplementary oxygen, and providing dexamethasone. These are the management of chronic lung disease. And diuretics in excessive fluid collection. Next, meconium aspiration syndrome. Meconium aspiration syndrome mainly term or postterm babies. They are the risk and small gestational age and perineal asphyxia, and is usually rare in preterm. You know what is mecon? This meconium aspiration is nothing but the newborns are inhaled the meconium. You know meconium. The first fecal matter passed by newborns, and it may cause fetal distress. What is a major effect by this meconium aspiration syndrome? Airway blockage, chemical pneumonitis, increased risk of infection, surfactant deficiency. These are the main causes from meconium aspiration syndrome. Next, management: thoracic compression and bronchial lavage, and also intubation for lower airway suction. Surfactant replacement therapy. Next, extracorporeal membrane oxygenation may be used. Next, pneumonia. Pneumonia can be congenital or nosocomial infection. This congenital will usually onset within 6 hours of birth, mainly caused due to bacterial, viral and other bacteria like streptococci, pneumococci, listeria or coliform bacteria, and viral like rubella outbreaks, coccoxyvirus and cytomegalovirus. Other than that, chlamydia, candida, toxoplasmosis. Due to this also pneumonia will cause. Next, if you are coming to the intrapartum is during delivery within onset of 48 hours. Causes same, bacteria are viral. Next, nosocomial onset after 48 hours means during hospitalization, caused by bacteria and viruses. Next, pulmonary hair leg, also we'll call pneumothorax. It's mainly occur in 1% of infants. It's usually asymptomatic. Here, over-destination of alveoli occur in immature lungs because of decreased number of pores of corn, which redistribute pressure between alveoli. So what it will happen, air will rupture through over distended alveolar walls and move towards the ileum. Ileum is where it enters the pleural or mediastinal space. It's mainly common in surfactant deficiency and meconium aspiration syndrome and pulmonary hypoplasia and pneumonia cases. Risk is reduced by lower ventilatory pressure. Like treatment, management like lower ventilatory pressure and surfactant replacement therapy. Upper airway obstruction, the neonates are obligated to nasal breathers. It's mainly happen due to conal atresia, laryngomalacia, subglottic stenosis, tracheomalacia. These are the causes for upper airway obstruction. This conal atresia, the incidence rate is 1 is to 8,000 neonates, more common in females. It's mainly due to failure of breakdown of bucconasal membrane. It may be unilateral or bilateral, or bony or membranous. It's 60% associated with other congenital abnormalities. If present at birth with respiratory distress and difficulty in passing nasal catheter, the management is nothing but surgical corrections and nasal stents. Laryngomalacia is common in first year of life. It's mainly increases due to supine position, activity, crying, upper respiratory tract infection. It's resolving within second year of life. Identifying this laryngomalacia, we will use endoscopy. And Perry-Robin sequence like consists of protruding tongue, small mouth and jaw and cleft lip. Incidence, it's 1 in 2000 neonates. It causes obstructive apnea and difficulty with intubation and aspiration. To maintain airway patency and prevent obstructive apnea, prone's position should be given initially. If the infant fails an oral airway should be inserted through intubation, evenly if they require tracheostomy. Surgical correction is the management for this. Next, subglottal stenosis. It's mainly occur risk factors like it occur with congenital problems or prematurity, recurrent intubation, prolonged intubation, traumatic intubation, black babies, a large or small endotracheal tube, gastroesophageal reflux infections. So, treatment is cryotherapy. Up to now what we discuss is our small topics, but main topics is respiratory distress syndrome. What is this respiratory distress syndrome? Respiratory distress syndrome is defined as the persistence of arterial oxygen tension is less than 50 mm of Hg and central cyanosis in room air. Respiratory distress syndrome is nothing but the persistence of arterial oxygen tension is less than 50 mm of Hg and central cyanosis in the neonates will called respiratory distress syndrome. It's happened when the baby's lungs is not fully matured and it's difficulty to provide oxygen and it causes difficulties in breathing. So incidence rate 75% around 28 weeks, 52% at 30 weeks of gestation. Use of surfactant can significantly reduce the risk of neonatal death. Clinical causes. What are the causes? Causes like pulmonary causes like hyaline membrane disease, meconium aspiration, pulmonary hypoplasia, bronchopneumonia, airway obstruction, and cardiovascular causes like congenital heart disease, heart failure, pulmonary hypertension, and non-cardiopulmonary causes like metabolic acidosis, hypoglycemia, asphyxia, birth trauma, drugs, hyperthermia, and intracranial injuries. So, what is the clinical manifestation? Signs and symptoms of respiratory distress syndrome 4 to 6 hours after birth: tachycardia, tachypnea, chest retractions, fine crackles, expiratory grunting, nasal flaring, central cyanosis, ventilatory failure, extreme